All right, and I hope you can now see those slides. All right, so welcome to polyendocrine metabolic ovarian syndrome, formerly PCOS. So this condition is caused by genetics, changes that happen when a baby is developing in the womb, or what we call epigenetics, and our environment. The primary causes are disruption of our endocrine system, which is our chemical hormones or messengers that float around in our bloodstream and actually can disrupt the entire body. There are many different types of hormones that are affected in this condition, but it manifests for those who have it with reproductive concerns, metabolic concerns such as diabetes, heart disease, increased weight gain, and many others, dermatological or skin changes such as acne, dark skin patches, and changes in skin and scalp hair, and also significant psychological effects, including anxiety, depression, and a major impact on quality of life. This is not a condition just of a woman's ovaries or of a person's ovaries. These are just some of the endocrine or hormonal chemical messenger disturbances that cause this condition. And yet we've known about this in the science, but it's not been reflected in the name or the condition to date. In fact, what we thought this condition was all about the ovaries. And this mistake was made 91 years ago when two surgeons who were doing an operation noted that women who had excess body hair often had these bumps or small little fluid sacs on their ovaries. They therefore thought that was the primary problem, called them cysts, and said it was an ovarian disorder. Quite a long time ago, we discovered it wasn't that it was actually much more than that and affected so much of a woman's experience across her lifespan and changed as she went on this journey. But one of the issues here is that because we had put it in a box of being an ovary disorder, the untold harm of that was very significant. The way medical terminology works is if you have a particular condition and it's in a specific box. So in this case, it was called an ovary disorder. The ovary disorder is actually secondary to those chemical messages, but it was put in the ovary box, which means any research that's done comes out of that tiny, tiny, tiny research bucket. That's why there has never been a single medication or treatment specifically developed for this condition, because there is simply no funding or research that's active in this area. When you don't have research, you don't have evidence. When you don't have evidence, you can't educate your health professionals. And in this case, when you're in the ovary box, the health professionals that have ownership or leadership over that condition are gynecologists, and often quite narrow. The gynecologists are focused on infertility or on some of the other manifestations. But all those other features, the mental health conditions, the skin, the metabolic features, and indeed many of the broader reproductive features were just not managed well. And that also led to the models of care that we have. So when we've been able to show that women or people with a condition are often not diagnosed and wait a long time to get diagnosed and don't get enough information, it's a feature of this system. It's not just the individual health professionals that look after them. And indeed, in my 6 years of medical school, I had 1 hour of education on this condition under gynecology. So how are we actually supposed to ever get our broader health professionals to understand the problem? So we needed to fix this. With 170 million women in reproductive age, greater than 70% undiagnosed until they get to seeking to have a child, and also a very long journey from the time that it was recommended there was a name change. So remember, these are not abnormal cysts in this condition. They're actually partly developed eggs that sit in a little fluid-filled sac. They don't get dramatically larger, they don't bleed, they don't cause pain, and they don't need surgery. So that cystic label is wrong. It's not just about the ovary, and it has lots of downstream harm because we've put it in that ovary box. And it doesn't recognise all those broader features that women with lived experience actually get exposed to across their lifespan. So what we did in trying to change this name was actually brought everybody together, and the most important people were those with lived experience. So this particular publication looked at, is there confusion? Do people want to change the name, and how should we go about it? It didn't ask so much what the name should be. And first of all, 85% of people believed that there were abnormal cysts, which just shows you how harmful the name could be. 86% of patients with the condition wanted a name change because they understood there were major problems and limitations with it, and 76% of health professionals supported them. And then finally, in a workshop, 84% voted to change the name. This was with 8,000 people from all world regions, and this is very important because it gave us the right to go on the journey to change the name. These are the patient societies and health professional societies that went on the journey with us from all continents and from most disciplines that are relevant. And this is the journey we went on. First of all, once we had the mandate to make a change, we got governance and funding. So we set up a structure so that we really had a strong voice from those with the condition or with lived experience. We did a massive global survey, and then we did a workshop with representatives from lived experience groups and patient groups and health professional groups from around the world. What we call consumer and community, or public and patient involvement, was absolutely at the table, co-leading this work at every stage. We then had some marketing input and further surveys and further workshops, and we've changed the name to PMOS and are now implementing this together. So we involved 22,000 in total, and over 14,000 of those were people affected by the condition. We involved 56 organisations, and we had 90 representatives at the final workshop. We adhered to the principles that they wanted us to respect. Scientific accuracy was the one that patients actually wanted the most, focusing on improving outcomes, reducing stigma with this condition instead of being secret women's business or only focusing on the ovary, improving communication, being culturally appropriate, and being something that can be implemented. And we kept those principles throughout. We also asked people what was most important: a new accurate name, a generic name like diabetes and asthma, which doesn't say anything about the condition, but also isn't correct and may not cause stigma, or if we keep the P, C, O, and S, but actually use different words. And those two latter ones were firmly rejected, especially by people with a condition that wanted a new accurate name. In fact, 82% of people strongly supported this, and most of the others were neutral. So we then went on a journey to what that name should be. And we looked at all the science about what the condition actually was. And the first term that was chosen through all those stages was polyendocrine, or lots of hormones, effectively. The second was metabolic, with all the features of this condition that are metabolic. And the third one was ovarian, because the ovary is significantly affected due to those chemical messages. We then put those terms into a new name and looked at all the different ways we could put those words together, made sure they weren't duplicating any other condition or anything else that's out there in the community. We considered language and cultural implications, we got marketing advice, and we ended up with 97% consensus, which is almost unheard of. And this was then published in the most important medical journal in the world. Now, the reason that matters is once you're published in this, it's a bit like the Bible of medical journals, and people will not question that it's actually been through a rigorous process. But this was just the next step. So having led the international guidelines at the request of patient groups who wanted us to do that for better care, we did that in 2018. We updated them in 2023. But until we could change the name and get this condition out of that ovary box and out of a gynecological disorder, so we got more research, we got broader education, and we got better healthcare, we needed to change the name as the next step. And so I'm now going to hand over to one of my colleagues, Mahnaz, who's going to tell you a bit about what we're now doing, having changed the name, as we go on the next stage of the journey.
Thanks, Helena. Hi, everyone, and thank you for joining us today, wherever you may be joining from around the world. So now that the global consensus process is complete and we have a new name, the next major step is implementation. Next slide, please. Can you please change the slide? Thank you. Implementation at this scale is complex. This is not simply introducing a new term into the literature. It requires coordinated change across education, communication, health systems, policy, research, international classification systems, and guidelines. For this reason, we developed a staged global implementation strategy, which is already underway. Next slide, please. A major part of implementation is dissemination. Alongside the Lancet publication, we've had a coordinated publication strategy across multiple areas, including research, clinical care, policy, women's health, and adolescent health. The goal is to ensure consistent understanding of the new name across disciplines rather than limiting it to reproductive medicine only. Next slide, please. One of the most important parts of implementation has been re-engagement with those 56 international societies that we had already partnered with. We shared implementation packs with them to support consistent communication across all regions. These packs include media resources, videos, animations, fact sheets, apps, newsletter content, media talking points, and local expert support. The aim is simply consistent messaging globally. Next slide, please. Accessibility and global reach have been major priorities here. Across our platforms, resources have already reached over 1 million views across 195 countries. Resources have been translated into multiple languages and are available through our platforms, including the Ask PMOS app. You can scan the QR code on the screen if you would like to explore these resources. And perhaps we can give everyone a few seconds to scan the QR code, and then we'll move on to the next slide, please. Right, thank you. Our patient and health professional resources have been co-designed and translated into 20 languages, including Spanish, French, German, Portuguese, Arabic, Mandarin, and Persian. It is important to note that translation is not simply changing words from one language to another. It also means considering culture, communication styles, stigma, and local contexts. This is especially important for a condition affecting more than 170 million women globally. Next slide, please. Implementation goes well beyond communication. Of our 8 implementation stages, the first 3 have already been completed within only 2 weeks of the official launch of the new name. The remaining stages that you can see with orange stars on the screen are already underway or planned. Importantly, this is intended to be a managed transition from PCOS to PMOS over several years rather than an abrupt replacement. Next slide, please. I think this slide captures perhaps the most important messages. The name change process was deeply patient co-led and co-designed from beginning to end. It has also become an example for how future changes in medical terminology may happen. Ultimately, this work shows that healthcare systems, research, and policy work best when they are designed with patients, not simply for patients. And with that, I think it is very fitting to hand over to Lorna, who will share what this change has meant from the patient perspective. Thank you.
Thanks, Mahnaz, and thank you everyone for joining tonight. It's amazing to have so many people here. So I've been involved with POSA now for over 20 years, and as a woman living with PMOS, and I've been involved with guideline development and various other projects along the way, but this is a really exciting development for so many reasons, because to accurately describe this condition that we live with, I feel gives us so much validity. I was talking with one of my husband's colleagues who is a similar age to me, so we're in our 50s, and I shared with her the new name the day it was released, and I got an email back and she said, "Oh, thoughts?" And I went on this off on a tangent about how it's not necessarily about the women of today, and it might feel a little awkward or whatever, but it's also about our daughters and their daughters. And in addition to that, it's not, as Helena said, not just about the ovaries, it's about our entire life. And she told my husband yesterday, "Oh, I have to thank Lorna because I've totally rethought my perception of this. So I'm actually going to go off to my doctor and I'm going to say, I have PMOS and what do I have to do? Because what was PCOS at the time, her story around that was she had to have IVF to have babies, and she talked about her IVF doctor delivering the medication direct to her house. Her children are in their 20s now. So I thought that was a really great sort of example of someone changing their mind about looking after themselves because of the long-term implications of what this condition can do. It's not just about fertility. So very excited about that, to have it accurately described. So I will hand over to the next person now.
My name's Anju Joham. I'm one of the endocrinologists at Monash in Melbourne and involved in this name change. So I would like to talk to you about different care models or models of care, so healthcare for women with PCOS. My slides are not advancing, so just a sec. Oh, there we go. So one of the things we did was survey different women with PCOS a number of years ago. And what we found was that many people were dissatisfied with care. And the reason is that it took women basically seeing more than 2 or 3 health professionals over a couple of years to sometimes get a diagnosis. Then when they did get the diagnosis, the information that they received at the time of the diagnosis was suboptimal, maybe partly due to time constraints. And then things like long-term risks and metabolic risks, psychological features, they weren't addressed well. And this is a common condition affecting 1 in 8 women, as we've heard, and it's estimated that 70% remain undiagnosed. So what is a model of care? So it's a multidisciplinary, person-centered approach to the diagnosis, treatment, and long-term management of a condition. So what this involves is having the patient in the center of that model, and we are trying to provide comprehensive, coordinated care that is equitable, and with hopefully within reach to everybody. It should be respectful, empowering, holistic, with focus on preventative care, and it should absolutely be collaborative and co-designed with those with lived experience, and the care provided should be evidence-based, based on research and real evidence. So a patient-centered framework, some of the features of that might include things like shared decision-making between the patient and the clinician, regular review across life stages, inclusive practice, and really looking at holistic care, not just the physical, but also psychological health, with focus on lifestyle intervention, looking at medical therapy options, providing psychological support and long-term monitoring of complications, including metabolic complications, so things like diabetes, blood pressure, cholesterol, and uterine health as well. And so the current systems, certainly that we have in Australia and in many systems around the world, they're very fragmented. They are siloed. So here in Australia, you might go see your GP for the primary care. Then if you have issues with your periods, you might see the gynecologist. If you have diabetes, you see the endocrinologist. And then if you have concerns with acne or skincare, you see the dermatologist. So it's very siloed. And a lot of the information people are getting is not really the best evidence-based information. And so, of course, the GP is usually the primary first person of contact and offers a lot in terms of lifestyle counselling, ongoing monitoring. But there is real value in bringing a multidisciplinary team together with the relevant parties involved, including focus on lifestyle factors and psychological health as well. So specialised services are something that can be very helpful, with dedicated clinics, often based, at tertiary centres, providing evidence-based care. And the other thing you might do is there might be research that service can kind of tap into, and it also would provide holistic assessment across the lifespan. Something like this is something that could be audited and potentially scaled up with a framework that can then be expanded to other sites as well.
So ideally, a care model like this should look at a patient-centered kind of biopsychosocial care with a lot of patient empowerment and education, with providing self-management support, education, providing resources, screening for emotional well-being, and if and if there is something that's detected, then offering the support for that. Lifestyle intervention is often thought to be the cornerstone of management of PMOS. So looking at how this might be achieved through dietitian or exercise physiology support programs, where there's weight management help required, that this can be provided. Then the skin concerns. Then with the reproductive phase of life, looking at preconception and pregnancy planning, so really early counselling regarding family planning. If there are challenges with fertility, what the pathways might look like, and then the long-term screening that we mentioned before. So one such example is a service that I've actually set up in Melbourne. So this was established in November 2017, originally staffed by endocrinologists, a dietitian and a dermal therapist who conducts laser hair removal. So a lot of the healthcare through public hospital networks in Australia is free. So pretty much everything in the service is free except for the laser hair removal. That is basically set at kind of cost price. The service has recently expanded to include a dermatologist, nurse practitioner, gynecologist, and a general practitioner. And this sort of model of care is something that we are working to develop a framework that we can basically help other health services kind of roll out a similar service. This is a huge body of work that has taken, 14 years from when the idea was first conceived. So this does not happen on an individual level, but absolutely on a team basis. So Helena and Mahnaz have led the charge in this, but supported by the people that you see here in the photo, which is basically a significant international network, not only of health professionals, but a lot of consumers. And the photo on the left is actually our research group here at the unit, who've had a significant role in supporting this journey as well. So we are happy to now take any questions. So I might stop sharing my slides. So with the questions, there are some people who have pre-submitted some questions. So I might actually start off with those pre-submitted questions. So I'm going to read out the question first, and then I'll allocate the question to one of our panelists. So the first question is, as someone who has suffered from various aspects of this syndrome for over 40 years, I'm interested to hear about the implications post-menopause. So I'll take this one. So with PCOS, one of the features is that PMOS is that women do get irregular cycles, sometimes absent cycles. So one would think that perhaps that does mean later menopause. And there is some evidence that perhaps this does happen, that maybe women with PMOS might get menopause a little bit later. But this is where the evidence is a little bit unclear. So it's not quite clear. What we do know for certain is that, PMOS is a polyendocrine metabolic disorder. So the metabolic features does not stop when the reproductive years finish. So it doesn't, the metabolic features in particular, even some of the dermatological features, psychological features, all those things can actually persist beyond menopause. So this is a condition that basically lasts across the lifespan. It doesn't stop at menopause. The next question I'm going to ask is going to be, so this one is going to be Lorna and Mahnaz. So what sort of resources do people with PMOS and healthcare practitioners need to ensure that their patients are informed and feel seen after a diagnosis of PMOS?
I can take this one. I think perhaps the most important thing people need after a diagnosis is clarity and access to reliable information. For many years, individuals with PMOS have told us they felt confused about what the diagnosis meant, where to go for help, and what they should do next. At the same time, we do know healthcare professionals also need clearer guidance, practical tools, educational resources, and support to recognize that PMOS is not simply a reproductive condition, but a broader endocrine and metabolic condition. That is why evidence-based resources are so important both for people with PMOS and for healthcare professionals. Resources need to be accurate, accessible, culturally appropriate, and available globally. So a major focus of our implementation work has been building these evidence-based resources through our platform and also our international collaborations so far. So that regardless of where someone lives, they can access reliable information and feel informed, supported, and understood after diagnosis.
Great, thanks, Mahnaz. The next question. Lorna, did you have anything to add with that one?
To back up what Mana says, I think that there's lots of untrue information out on the internet. So going to trusted sources such as the Ask PCOS app to get that evidence-based information that is backed in science and lots of research I think that is the best place to start for that kind of thing as well. Yeah.
Great, thanks, Lorna. The next question is going to be for Helena. So is there a connection between PMOS and other conditions such as Crohn's disease, which is an inflammatory bowel disease condition, endometriosis, POTS, which is postural orthostatic tachycardia syndrome, EDS, hypermobility, which is a condition called Ehlers-Danlos syndrome, and ADHD, attention deficit hyperactivity disorder? Helena.
Yeah. Of those chemical messages systems around our bloodstream is that the effects are very widespread, and also they change in an individual person across their lifespan. They're very different. Even in childhood there's effects, and then in puberty, and then in reproductive years, and then as we approach menopause and beyond. So across a person's lifespan they change, and then between individuals they're quite different, especially people in different ethnic groups or from different world regions. But there are some associated conditions. Now, many of the ones listed there are actually not that strongly associated. For example, some of the hormone changes that occur in endometriosis actually are even less likely to occur in this condition. And when you start to think about other conditions, there are some associations. So there's some possible associations with POTS, or that postural blood pressure drop that people can get, which is often also associated with fatigue. And there may be an association with ADHD or attention deficit disorder, but again, not really strong. However, there are associations with many other conditions. So the thing about the hormonal changes is that they cause inflammatory changes, they cause changes with our nervous system, they cause a lot of other changes in different parts of the system. And that's why there is a lot of complex associated conditions. For example, thickening of the womb lining and a precancerous change in the womb lining, and even rarely, but still possible, an increase in cancer of the womb is associated with this condition, but endometriosis is not particularly. Larger ovarian cysts that bleed and cause pain, they are not associated with this condition. You can have them, but they're not of any higher increased risk than they would be otherwise, because what we're seeing here is as fluid-filled sacs around eggs, not actual formal cysts. So there is a long list of things that are associated, but most of those that were outlined in this particular scenario have not been associated with the disorder.
Great. Thank you, Helena. The next question I'm going to address is, said, I look forward to hearing more about practical applications for how we can increase awareness around this condition for earlier assessment, treatment and management as well. So I might take this question. So one of the things that has been really helpful for awareness is actually this name change process. I wasn't actually in the country when the name change happened, but I came back to my 14-year-old daughter telling me what the new name was. So I think this has had a really unprecedented kind of reach. We've really been able to spread the news about the name, but along with the name, it actually brings awareness to the condition and what it actually truly truly is. The fact that it is an endocrine condition, metabolic condition with reproductive features. So I think just the name change on its own actually brings a lot in terms of awareness. The name change builds on a lot of the foundational work that we've already done. So a lot of us have already contributed to the international PCOS guidelines that was first released in 2018 and then in 2023. So that has done a lot of hard work in really kind of summarizing a lot of the evidence in a lot of the key areas in PCOS. And it's important to note that none of that actually changes because all that evidence still stands. The name of the condition has changed, but in terms of the management, a lot of those things are, as we've kind of discussed in the guideline, of course, things are always changing in terms of future research. There are new important questions that need to be asked, and these will be addressed in future research and future guidelines as well. Helena, do you have anything to add there? We've lost your sound. Helena, you're on mute.
Oh, sorry. Yes, I would agree. It's important to know that we've reached already over 600 million people around the world with the media campaign that's there. There's every medical discipline. We're going to present at their conferences and they're publishing their journals. All of the top universities in the world will be informed. The implementation strategy that Mahnaz described is unprecedented and has never happened at this scale before. So it's not one strategy, it's a raft of strategies. And the most important thing will be getting the condition out of that ovary box and into a much broader understanding of what this condition really is. And that will take time, but it will happen. It just won't happen overnight.
Absolutely. Now, the next question is, will the name change also help ensure that a healthy lifestyle is looked at? Helena, I might allocate this to you.
Yeah, so one of the things about recognising this as a metabolic disorder is we will be really emphasising how important a healthy lifestyle is, but we will also not be representing that a healthy lifestyle is a secret to success for everybody. So many people with this condition actually start to gain weight even in their childhood, and they gain weight. Not everyone, but often they'll gain weight at a faster rate than others, and that makes the condition worse. And the condition also makes that weight gain in turn more difficult. So what we have to understand is that the most important role of healthy lifestyle is to help support people with this condition to be the healthiest they can be, and to prevent, wherever we can, further or more rapid weight gain and to keep them healthy. But when we're talking about things like if someone wants to manage their weight, and not everybody does, but if they do, then we need to make sure that we're actually giving them advice that's effective. So healthy lifestyle is great to keep them as healthy as they can be, but not be unrealistic about what that will offer. And then also talk about what other medical strategies, and even in some cases surgical strategies, do actually work and may actually provide additional support. For far too long, we've simply dismissed healthy lifestyle as, eat less, move more, and you'll be fine. And if you don't succeed, then it's, it's a personal failing. Whereas we know that actually so much of this is our environment, and to some extent, it's also this condition. And so it's important that we absolutely put healthy lifestyle front and centre to keep people as healthy as they can be, but we also don't set people up to fail and set unreasonable expectations and stigmatise people with this condition and set them on a lifelong yo-yo with unrealistic expectations about what that lifestyle change can deliver.
Excellent. Thank you, Helena. We've talked a bit about metabolic health now, so let's look at reproductive health. So, Mahnaz, how does PMOS affect pregnancy?
Well, PMOS can affect pregnancy in multiple ways because it is not simply a reproductive condition as said. It is also an endocrine and metabolic condition. Individuals with PMOS have higher rates of complications, including miscarriage, gestational diabetes, high blood pressure during pregnancy, preeclampsia, preterm birth, and some complications affecting fetal growth, mainly giving birth to a smaller size babies. These risks are thought to be related to the underlying features of PMOS, including insulin resistance, hormonal changes, inflammation, and higher rates of overweight and obesity. Importantly, this does not mean that individuals with PMOS cannot have healthy pregnancies. Many absolutely do. What it does mean is that awareness, earlier identification, appropriate monitoring, and better support during pregnancy are important to improve outcomes.
Great. Thank you, Mahnaz. So just got a question come up in the chat. So Helena, this one's for you. How will this new name change diagnosis and phenotypes?
Yeah, importantly, the condition is the same. So we are not changing the diagnosis because actually the diagnostic features are related to those hormone changes. So the diagnosis doesn't change, but hopefully will be much more common than it has been in the past. We need to be really careful about the concepts of phenotypes. This was a scientific misclassification or inaccuracy that happened. We thought there were multiple small groups of people who had this condition, for example, people who were lean or not overweight, people who had particular types of features and not others. But in fact, it's been shown that it's a spectrum, which means it's a sort of straight line of people who can sit anywhere on that line rather than groups. And also phenotype implies that it's linked directly to our genes. But when we looked at the genes, we can't relate that directly to the features that an individual experiences. So in fact, most of the evidence now shows there's not really subgroups, but rather a spectrum. And the most important thing is to understand the particular characteristics a person has, their particular life stage, and therefore be able to explain to them with what we call precision medicine or individualised care what your PMOS likely looks like and what your PMOS at this life stage and in future will mean for you, and therefore how we tailor your treatments to you, rather than trying to put you in different smaller boxes, if that makes sense.
Thank you, Helena. Question for you, Lorna. What role did those with lived experience of PMOS have in the name change?
Massive roles for many years now. So consumer groups from around the world were involved with this process. I was part of the international committee, as were consumers from other parts of the world, UK, US, and various other countries as well. So our voice was well and truly heard, and there were lots of discussions about potential names and the implications for particular words being used. So yeah, our voice was well and truly heard. And of course, there were the surveys that were shared out to the consumer groups globally that everybody had the opportunity, if they saw them, to take part in those as well.
Thanks, Lorna. And in terms of the ICD code change, so Helena, when will the ICD code change and who is responsible for changing it? And I will add to that, and what is the impact of that being changed?
Yeah, so thank you. So the people who led the initiative are responsible for changing the name, and indeed that includes the whole team who are doing this. So the process is already underway. We have to apply to the World Health Organization. That's already happened, and it will be reviewed later this year in their usual review process. What they require is evidence of professional society engagement, patient and health professional engagement, and there has never, ever in a name change been that much professional society, patient and health professional engagement. So we should not have any trouble with that. That's the name change itself, which will be considered in October and should be released early next year. But more importantly, the next part, which is stage 2, is applying to change the classification out from an ovary condition to a broader condition. And that will happen in 2027 because that's the next opportunity that we can actually do that. So that's how, and it's who's responsible. In terms of the impact, absolutely massive. And not so much the name change, but actually that reclassification. Because then we come out from only ever getting funding and research for ovary disorders and only primarily educating people about ovary disorders and only providing care predominantly from that model. So that the potential benefits of that are absolutely huge, but they will take time.
Thank you, Helena. And last question for you, Helena. So this actually can be Mahnaz. Mahnaz, actually, you might want to start, and then Helena, maybe you can finish off. So where and why was the research published?
I think we covered this a little bit in the presentation. This work was published in the Lancet because this is a global issue affecting millions of individuals worldwide and requiring international attention. However, publication in the Lancet was only one part of a much broader strategy. We are also publishing across discipline-specific journals because the implications of PMOS extend far beyond reproductive medicine. Endocrinologists, fertility specialists, obstetricians, dermatologists, psychologists, primary care clinicians, policymakers, and many others all need to understand what this change means for their field and their patients. Importantly, this is also about highlighting that women's health matters. A condition affecting more than 170 million women globally shouldn't have remained overlooked for so long. Publishing across disciplines also helps researchers, funding bodies, and healthcare system recognize that PMOS is relevant to their area, encouraging greater investment, research, education, and a better care ultimately.
Excellent. Actually, we've got a couple more questions that I've got in the chat, actually. So I'll take one of them. So in rural and remote areas, how do you educate GPs? So here in Australia, for example, there is lots of education that is provided to GPs, including specifically about women's health. So when the 2023 guidelines came out, Helena and I basically did a tour of Australia and kind of visited 5 of the, I must say it was the cities where we provided education, but in these cities, they would be about some of these cities, there'd be 2,000 GPs. And these meetings are actually well attended by GPs who I would say would live throughout the state because it's a very good educational program. The other thing is there's a lot of remote learning as well. So there's been a lot of webinars, a lot of different educational materials that are actually available remotely as well.
And the only thing I'd add to that, Anju, is that sometimes, especially when there's a big change like this, we all need to work on this together. So the Ask PMOS app is free, government funded and evidence-based, but it allows people with the condition to understand more about their condition, but then to take that information to their GPs and almost educate their GPs as they go because they've got evidence-based information to take with them. So part of this is about empowering people with the condition and taking GPs on the journey and making sure they're aware. And primary care, if you're in other countries, it's not always called a GP. But yes, sometimes we're going to have to work together to get there. Although we will be working on it, it will take us a little bit of time. So if you don't want to wait, get the Ask PMOS app and do this with your healthcare provider.
And last question that's come in the chat, I'll give it to you, Helena. Does being diagnosed with PMOS in early teens change your diagnosis in adult years? And can it be blamed on weight?
Okay, so once you have a diagnosis of a condition, it's lifelong. But it may change. It does change. We know in adolescence it's different to how it manifests when you get older. And as Anju said, often it'll have different features as you get older. We do know that people with this condition do tend to gain more weight than without it, and that weight does create or exacerbate the condition. But not everybody gains excess weight, only some. So it is a two-way street. You're more likely to gain more weight, but you're also more likely to get severity and even the diagnosis because of that. That's the metabolic part of the condition. And every person's journey is unique. And so it's really important just to understand that you need an understanding of your condition.
Helena, that's the last of the questions. So would you like to wrap up?
Yes. So just to say thank you to everyone for attending. This will be recorded and will be available after the session as well. There's plenty of ways to find information, and indeed we'll put that link in the chat. Amanda, if you can do that. And I think that the important thing is to make sure that you know as much as you can that is accurate about this condition. There is so much misinformation out there, probably because the health system and health professionals have failed to meet the needs of people with this disorder. And we really hope to be able to change that. But just make sure you get information from reliable sources and understand that the name change was necessary but not sufficient. And that implementation plan, which is well and truly underway, including changing and updating the guidelines to the new name, which will happen within weeks. And then that will be PMOS, formerly PCOS, and then changing completely to PMOS as of 2028. So all of that work is currently underway. And we really do hope, and more than hope, actually know already, that this change is already making a difference to people's awareness and hopefully their rate of diagnosis. And I also just wanted to thank the team and the amazing contribution from those with lived experience during this journey.
Thank you, Helena, and thank you everyone for your time.
Thank you.